Are you good?
Yeah.
Okay.
Antes de empezar, profesor, que usted lo presente, déjame decirle en español un par de cositas.
Ajá, diga.
Nada, saludos a todos, ¿verdad? Buenas noches, pues estamos mucho, digo, ya estamos de noche en todos lados. Así es que la diferencia ahora, yo tengo dos horas de diferencia de ustedes y Megan y Claire tienen una hora de diferencia, igual que la profesora Benedetto. Gracias por venir, ¿verdad? Gracias por estar con nosotros. Le queremos dar las gracias a Megan and Claire to be here, to spend the time with us, to talk about this topic that is very, very, very good and unique because not all the people knows about this topic. And with all the years, the proof of running in women's is getting higher. So, and in Puerto Rico, they love to run. To be honest, one of the favorite sport in Puerto Rico is run. Is what it is. Basketball, baseball, and running is one of the best. So, importante, los que quieran pueden poner el closed caption. Si ustedes van a, si no me equivoco, a More, ahí dice que dice captions, el segundo, y ahí pueden poner el caption y pueden, todo lo que se diga, lo pueden estar leyendo también ahí por si acaso quieren hacerlo de esa manera, ¿verdad? Eh, eh, la conferencia se va a grabar y si Dios quiere, pues se subirá en la página de Period Day en YouTube pronto. Se puso en el chat los artículos que ya van a mencionar en la presentación. Si ustedes no los ven, me dejan saber cualquier cosa. Yo voy a poner el email de Period Day en el chat y pues nos pueden escribir y yo se los puedo enviar en confianza. O sea, si tienen problema en bajarlo o que no los vean o qué sé yo. Así que con todo eso, le quiero dar las gracias también a los auspiciadores, ¿verdad? Que nos han ayudado siempre en todos nosotros, en todas las cosas, Benud Corp, Best Option, Cyber Therapy, Raúl con su compañía de Puerto Rico Physical Therapy, ¿verdad? Eh, Todos, de verdad que se le agradece que estén, que nos ayuden, ¿verdad? En todo esto. Así que sin más, nada que tenga que decir, profesora, todo usted.
Gracias, buenas noches a todos. Es un gran placer estar con ustedes y presentarle a Claire Todd, DPT, y Meghan Nally, DPT, ambas que son especialistas en rehabilitación de mujeres embarazadas que corren durante y después del embarazo. Además, tienen especialidad en rehabilitación pélvica. Claire lleva más de 10 años, casi 10 años de terapista física. Megan 3, las dos hoy día trabajan en ¿cómo se llama? Ambulatorio, Luis, así se
Sí,
dice.
en el hospital, pero en
En
el
el
área
hospital
ambulatoria.
de la Universidad de Pensilvania, en ambulatorio ortopédico. Claire fue estudiante mía, así pues, yo estoy muy, muy, muy orgullosa. Estoy muy emocionada, entonces voy a dejar que ella hable un poquitín sobre su experiencia en particular con las mujeres. Gracias y muy buenas noches. Claire and Megan, please, just a brief introduction about your particular expertise with women, pregnant women, and running.
Yeah. Hi, I'm Claire. So, as Maria said, I'm a physical therapist in Philadelphia, specializing in pelvic health and orthopedics. I'm also a running coach. So, I coach runners mostly long distance from half marathon to 100 miles. And I'm also a runner myself. I've run Boston Marathon multiple times, and I've run 100 miles myself as well. So it's truly my passion, and I love that I can meld both worlds together of orthopedics and pelvic to treat the pregnant and postpartum runner.
I'm Meg. I work with Claire actually, and I also treat the pelvic floor and orthopedic populations. I am not a running coach, and I like to run, but not like Claire. Claire's the runner here, but I played high level sports for a long time. So working with Claire and getting to know Claire, she's piqued my interest in trying to maybe rehab some runners here and there, but I also do enjoy treating pregnancy and postpartum, getting people into or back into exercise throughout that cycle.
Awesome. Okay, so we can get started here. Meg's going to start us out.
Hi. So the goals of this presentation are to summarize the benefits and safety of exercise during pregnancy with guideline support, to show common changes during pregnancy that affect movement, to connect frequent pain problems to simple treatment ideas, and to give step-by-step return to run plan for the postpartum period. Go ahead, Claire. Exercise in pregnancy lowers the risk of gestational diabetes and hypertension. It reduces constipation, incontinence, depression, and cesarean birth. Many patients report less back and pelvic pain. Exercise during pregnancy supports a healthy weight gain, and it keeps the heart and lungs strong. With an uncomplicated pregnancy, regular exercise is safe and helpful for all women. So the current ACOG guidelines for exercise during pregnancy recommend about 150 minutes of moderate intensity aerobic activity per week. Examples for this include biking, brisk walking, swimming, modified yoga, and Pilates. The ACOG advises avoiding contact sports, high-risk fall activities, activities over 6,000 feet in altitude, motionless standing activities, and prolonged supine exercises. When exercising, pregnant patients should be aware of the risk of potential dehydration signs, including dizziness, a racing or pounding heart, and urinating in very small amounts or having urine that is dark yellow in color. To avoid overheating, it is important to remind patients to drink plenty of water, wear loose-fitting clothing, and exercise in temperature-controlled areas. Do not exercise outside when it is very hot or humid. Educate patients to avoid standing or lying flat, especially in the last trimester, as these positions cause your blood pressure to decrease for a short amount of time. When patients lie on their back, the uterus presses on a large vein that returns blood to the heart. Standing motionless can cause blood to pool in your legs and feet. These positions may cause your blood pressure to decrease. According to the ACOG, if your patients begin to feel dizzy or faint, experience shortness of breath before starting exercise, have chest pain, a headache, calf pain or swelling, regular painful contractions of the uterus, or bleeding and or excessive discharge, it is important that they stop exercising immediately. As guidelines, the guidelines we have just discussed were published and last updated in 2020. As clinicians, we are aware of how quickly rehabilitation and medicine advances, and it should make us curious to investigate the most up-to-date current research surrounding this topic. Elite female athletes often state that they receive insufficient information during pregnancy regarding training recommendations that ensure the safety of both mother and fetus. Pregnant people are a very protected group in research for obvious reasons, but more often than not, it means many of our more elite runners are left without answers and guidelines. This begs our main topic of discussion today. What does this mean for our more avid high-level runners? For the purpose of this presentation and per research guidelines, a high-level runner is defined as a person who is committed to running specific structured and or periodized training at least 3 times a week, are developing proficiency and skills required to perform at a high level, and are regularly competing in competitions or races at the local or national level. The guidelines from the ACOG state evidence was not identified regarding the safety or additional benefit of exercise at levels significantly above the recommendations. Thus, pregnant athletes, most of whom are used to regular training at significantly higher intensities and volumes than the recommended 150 minutes per week, are advised to seek guidance and supervision from the prenatal care provider to ensure optimal growth of the fetus and to monitor any contraindications to continued elevated training. Despite multiple small cohort studies, single athlete case reports, and multi-sport and cohort, and even the International Olympic Committee experts' 5-part series on exercise and pregnancy, there is limited published data examining training in elite athletes. These studies demonstrate elite athletes are undertaking training volumes approximately 3 to 4 times evidence-based published guidelines, and even in the third trimester. The purpose of this study was to quantify training and competition performance outcomes of elite runners throughout pregnancy, postpartum, and post-pregnancy. The study utilized runners who were training at volumes to 2 or 3 times greater than the current 150-minute training period per week exercise recommendations, and found there was no significant adverse outcomes and no significant decline in performance. It's concluded that runners can safely continue to perform at their sport in tier-specific levels during pregnancy to ensure optimal maternal and fetal performance outcomes. It's important to discuss the changes occurring at different structures and systems in the body throughout pregnancy. Postural changes during pregnancy progressing down the kinematic chain include tight, shortened cervical muscles, stretched, weakened thoracic muscles, forward shift of center of gravity, increased anterior pelvic tilt, stretched, weakened abdominal muscles, tight, shortened lumbar and proximal lower extremity posterior chain muscles, genu recurvatum, and pes plemus. Common gait deviations seen are decreased stride length, decreased velocity, decreased thigh acceleration, decrease in swing work and pelvic rotation, increased stride width, and increased reliance on glutes and gastrocnemius over quadriceps at both the hip and the knee joints. The endocrine and cardiovascular systems are two of the most influenced throughout pregnancy, each with sizable impacts to the elite runner. Pregnancy is characterized by adaptive changes in physiology, endocrine, and metabolism, which are influenced from the mother, placenta, growth formation, and fetus itself, as is listed in the yellow box for your viewing. Together, these result in increased joint laxity, metabolism, blood glucose content, cortisol, insulin production, and resistance to insulin. The cardiovascular system undergoes significant changes throughout pregnancy as well. There's an increase in fluid retention, blood volume, blood pressure, and cardiac output. As a result, these combined with decrease in vascular tone can result in soft tissue compression. Blood coagulation time and content are increased during pregnancy as well, and vascular remodeling occurs at the uterine vessels. Sacroiliac joint, pubic symphysis, gluteal musculature, lumbar spine, abdomen, hip, and breasts are all among the most common complaints of pain in pregnant runners. If left untreated, these can result in running cessation during pregnancy. To support patients who wish to run during pregnancy, it is essential to understand the sites, severities, and personal risk factors associated with musculoskeletal pain. When it comes to running compensations, overstriding is among the most common seen, which is worsened by increased anterior pelvic tilt as well. Additional compensations seen include shortened stride length, increased pelvic drop, and decreased contralateral trunk rotation. In both the second and third trimester, hip flexor moments are found to be smaller. This causes reduced hip drive, allowing for the foot to land underneath the body, which incidentally also worsens overstriding. Pregnant patients in the third trimester specifically will develop decreased contralateral rotation, an increased average amplitude of erector spinae during swing phase, and decreased gluteus maximus percent during stance and medius percent during swing. While, of course, the plan of care is based on patient-specific chief complaints and changes, we have compiled an interventions pathway guide that we personally prioritize based off of what research indicates that is important to address and target for both runners and pregnant runners. The first step should always be to calm initial pain and the most bothersome symptoms. Rotation, back extensor, and core strengthening should be emphasized to target decreased trunk rotation. Single leg interventions are important to implement so long as the patient is without significant pain. Important proximal lower extremity muscle groups for the practitioner to prioritize are the adductors, abductors, glutes, and hamstrings, especially in eccentric moments. Of the distal lower extremity muscles, it is important to emphasize soleus strengthening to encourage landing in a bent knee position, along with targeting the posterior tibialis and everters to mitigate excessive pronation. Addressing running mechanics during pregnancy can be difficult. However, cadence, overstriding, and reducing velocity are all valid components to adjust. For your viewing over the next 2 slides, we have included some exercises that we often use in our own practice, each accompanied by a picture of the intervention. From left to right on this first slide, we have a short lever Copenhagen, a single leg weight shift, abduction hold, bridges on a ball, and split squats with a heel raise. And if you look close enough at the second picture, you'll see Claire. From left to right on this slide again, we have foot doming or arching, toe yoga, bird dog with added therabands, and anti-rotation pull with a Pallof press. A Run DNA continuing education course for gait analysis and retraining is referenced in this slide. We learned that on hierarchy on most important from changes overstriding. Sorry, Claire, it's not loading. My slide's not loading.
Oh, this is just a marching drill to help with overstriding. So, this is a way you can have the patient just march in place, or you can even have them lean into the wall to help with the forward lean. But yeah, this is just one of the many ways that you can correct form. Okay, thank you, Meg. So when discussing training with pregnant runners, they may mention different types of runs. So I thought it would be useful to have a basic understanding of these runs so you can appropriately advise modifications if needed. So as Meg mentioned, heart rate is elevated at rest and in exercise during pregnancy. So it's unreliable to use heart rate for training. So we'll use RPE, rate of perceived exertion, to achieve appropriate physiological benefits of workouts. Many articles focus on RPE on the full 6 to 20 scale, but for simplicity and based on my coaching training, I converted to the modified RPE scale. This chart depicts based on talking and breathing and how it correlates to different types of runs. So the first two you'll see are recovery and easy runs. These are aerobic training. This is aerobic training, which allows your body to break down fats into fatty acids, and which is a usable source for energy for efficiency. This is where 80% of running should be in training for everyone, and this is where a lot of training lands for pregnant people. Also wanted to touch on tempo run. The goal of a tempo run is to improve efficiency of energy production, so the use and storage of glycogen. It is deep and labored breathing, and it's a work to rest ratio of 2 to 1. Time and intensity is 30 to 60 minutes. And then the last one on this list here is a VO2 max or interval run. So the goal is to maximize aerobic power via utilization and delivery of oxygen. So it's hard running, but not sprinting, and short and rapid breathing. This is a little bit less common to see pregnant runners doing these workouts, but a lot of elite athletes will continue these types of workouts as well. So I wanted to walk through how training changes during each trimester, starting with the first trimester. So barriers to training are morning sickness, of course. It often impacts training in the first trimester. So while physical changes may not yet be visible, there's significant hormonal and cardiovascular changes that are already happening. The big question is, can a trained runner continue training at the same level once they have a positive pregnancy test? And it definitely depends. So there's, like Meg was saying, there's limited research that exists on advanced runners during pregnancies, as studies typically exclude pregnant women. Though there's no adverse effects that have been found, there's still caution that's advised due to the increased risk of miscarriage in the first trimester. So some recommended modifications for safe training include an extended warm-up for gradually increasing the heart rate and optimized blood flow, Cooling strategies, so using a cooling towel, fans, indoor treadmill during hot weather. Hydration, electrolyte intake, so before and during exercise sessions to maintain adequate fluid balance. I'll actually have a lot of my athletes get a sweat test so they can find out exactly what they are losing so they can replenish. And then also being aware of the higher caloric demand in pregnancy, it's worth recommending a consult with a sports dietitian. And then lastly, don't forget to check for any changes in shoe fit, as foot size can shift during pregnancy, usually a little bit later into pregnancy, but still a good conversation to have. So these are some examples of warm-up exercises to perform prior to running, which may prime the use of glute muscles, which we know can be harder to access for pregnant people based on structural and gait changes. So just some examples here show active hip flexor mobility, hip rotation mobility, standing clams, and single leg bridges. You can also just utilize more general cardiovascular and mobility exercises, such as butt kicks, leg swings, high knees, jumping jacks, walking, things like that. Okay, so moving on to the second trimester. So there was a recent study in 2024 called Cool Mama, which examined thermoregulation in pregnant athletes in their second and third trimesters by having them perform 5 intervals of challenging 5-minute treadmill runs at roughly 90% of their max heart rate. And remarkably, the pregnant participants maintained lower core body temperatures compared to the non-pregnant controls, never exceeding the critical threshold of 39 degrees Celsius. They also showed improved cooling mechanisms evident through increased skin temperatures and significantly greater sweat production. These findings indicate that pregnancy may enhance the body's ability to regulate heat, supporting the safety of continued intense training during second and third trimesters, which we'll call the second trimester kind of the sweet spot for training. I thought this study was really interesting, and it just shows that our bodies know what to do and how to adapt. So if feeling good, this is a great opportunity to continue speed work with shorter intervals of tempo runs, which again are those runs at that 8 to 9 out of 10 RPE. Fartleks, which are those short speed surges, which can be unstructured, so running quickly to different landmarks to achieve tempo benefits. And then strides, which are usually 20 to 30 seconds of very fast running, focusing on form. So as pregnancy progresses into the third trimester, there's more postural changes that make it challenging to continue training at the same level as the first and second trimesters. It's helpful to lean on cross training here. So I mentioned aqua jogging on this slide, which is actually a very challenging workout that simulates running by using a floating belt in the pool and kicking your legs and arms to stay above water. It's very challenging, and many professional runners use this during injury or later in pregnancy to maintain fitness. Uphill running or walking also naturally encourages a slight forward lean, aligning the body's position with a new center of mass. This can promote better posture to engage the glutes and core muscles more effectively. It also naturally reduces impact forces due to a shorter stride and decreased landing impact. Most runners keep training easy, especially in the third trimester, but there are high-level runners and professional runners who do keep some intensity. So these are some garments to support your runner in pregnancy, and then some on the next slide, some sports bras as well that can be used in pregnancy and postpartum. I really like the first one here, the maternity fit split. That's probably the one that I most regularly recommend. Oh,
Hello?
everyone okay?
I think so.
Yeah.
Okay. Yeah, so this first one here, the maternity fit split, is definitely my favorite. And these are some sports bras. You can find these online or at your local running store there in Puerto Rico. And I wanted to just mention some prevalent postpartum conditions to be aware of, and which also support the idea that we need to slowly progress an athlete back to exercise, such as running postpartum. So the first one you see here of the abdomen, this is diastasis recti. So it's a separation of the rectus abdominis, which needs to happen during pregnancy. Those muscles need to move to accommodate for the pregnant belly. But there are changes in the linea alba, that connective tissue between, and it's very common. And width alone is less important than the tension and function of this area. So things to look out for are doming or coning. So it's like a puckering of the tissue in the middle, which would show that the patient has poor pressure management. Also look out for pain, although much less common. In PT, we teach pressure control, deep core coordination, and then gradual loading of this tissue. And then on the other side of the page here is a pelvic organ prolapse. So this is also very common, and it is the descent of pelvic organs through either the vaginal or rectal canal. And it may feel like heaviness, bulge, or dragging. Patients might say it feels like something is falling out, and symptoms can increase in gravity positions in like standing, walking, lifting, or impact exercise. Also important to watch out for urinary incontinence, musculoskeletal pain in the back, hip, SI joint, and the foot and arch. Okay, so now onto the postpartum roadmap. So these weeks are guides, but capacity and criteria are what are really deciding on the progression. So in the first 2 weeks postpartum, our priorities are recovery and gentle reactivation. At this time, tissue repair is ongoing, sleep is fragmented, and energy will vary day by day. I always teach diaphragmatic breathing as a pressure management skill rather than a core workout. I cue an inhale that's relaxed with belly big and rib expansion, followed by a slow exhale that lightly recruits the deep abdominal wall and pelvic floor without bracing. This is something that I actually teach to every patient who comes in the door, but especially important in the first few weeks postpartum. I also address ergonomics for feeding and carrying to reduce strain through the spine. And then movement stays light, short, frequent walks that can be split across the day, gentle mobility to restore range of motion as well. And we definitely avoid high intra-abdominal pressure and any impact work at this time. Things are mostly healing at this point. By weeks 3 to 4, I reintroduce some foundational patterns at a very low load, emphasizing control and coordination rather than intensity. My progression typically includes bridge variations, bird dogs, sit to stands, light carries, things like that. Every movement is paired with breath, so pressure and load are managed better together. So for example, if you take a bridge, we use a soft inhale to prepare, and then a slow exhale to rise, allowing the deep abdominal wall and pelvic floor to participate. In weeks 5 to 6, I expand the work into functional endurance and controlled loading. So some staple functional movements, I use our squats, hip hinge, lunge, calf raises. I'll then move into more single leg strengthening if tolerated. In general, I love to use baby as resistance for exercise, as this is very functional for the parent. From week 7 onward, the goal is progressively load impact tolerance. So if symptoms have been fine, I introduce simple plyometrics like pogo hops and jump squats, beginning with low volumes and long rests. I coach a soft bent knee land with forward momentum over stacked joints, and I ask for quiet feet to emphasize control. Something I like to start with before even jumping and going airborne is like a heel lift or a heel rise and then a quick land into a squat. I think that's a really nice thing to do before actually jumping. I also really like kettlebell swings for that more explosive and reactive movement. So those are some things I might even do before having people jump off the ground. So before return to running, I look for consistent success across strength tests, daily function, and these light impact drills. Only then will we consider a walk run plan. There should be no pain, no sense of heaviness or bulge, and no urinary leakage during the session or in the day that follows. If symptoms do appear, we just step back a level, address the limiting factor, and then retest. So now that we have a practical timeline, I want to place it inside a decision framework. After birth, we use two types of guidance. We begin with a time-based starting point that respects healing, and then we advance using criterion-based progression that depends on what the patient can do without symptoms. I'll start with Goom and colleagues' recommendation, which I think Louise put that in the chat. And this is when to begin considering running and how to screen it. And then also in the chat, I'll show you Christopher and colleagues' criteria that moves the athlete from one level to the next. So Goom and colleagues recommend waiting until 3 months to start running based on required healing time of the levator hiatus and vaginal deliveries and abdominal fascia healing in C-sections. Levator hiatus is just the pelvic floor muscles that are surrounding the vaginal opening that gets stretched during delivery. The key item from this study was the strength and load impact screen for return to run readiness that the authors created and that I use in clinic with these patients as well. So the strength assessment includes a functional strength testing, 20 repetitions of single leg calf raise, bridge, sit to stand, and lying hip abduction. And then a load and impact screen, which the patient should achieve the following activities without pain, heaviness, dragging, or incontinence. So walk 30 minutes, single leg balance for 10 seconds, single leg squat 10 reps bilaterally, jog in place for 1 minute, forward bounds 10 times, hop in place 10 reps, and single leg running man. These are all outlined on the following slides. With these, it can be really nice to use a slow motion video capture on your iPhone to look at form, and then you can also look back on this as you progress through the training plan. Okay, and then Christopher and colleagues established a decision tree for return to running and focuses more on meeting criteria rather than a specific time frame like the Goom article. In their decision tree, they do use Goom's running readiness screen. They also establish strength and return to running progression plans. So strengthening targets the pelvic floor, abdominals, glute med, and foot intrinsics. Strength and running do not have to be at the same phase. They can progress asynchronously. And strengthening progresses from isometric to isotonic to plyometric in 4 phases. So for example, if you take the foot, it will start with foot doming, then go into single leg heel raises, and then hops with a dome. We'll progress through strength phases once a patient can demonstrate good motor control and biomechanics with all exercises. So not showing any abdominal doming or compensations and no symptoms. The therapist picks what phase to start a patient based on their assessment, clinical judgment, and ability to perform each exercise. Okay, so I wanted to walk through their decision tree on this slide. So first we walk start with walking. The athlete must tolerate 30 minutes without symptoms. We then run the readiness and impact screen I described with the GOOM article. I also check sleep, pain, fatigue, nutrition, and the athlete's recent aerobic work to make sure the body is prepared to handle additional loading. If these checks are passed, we choose the running entry level by criteria. It doesn't have to be level 1. Entry depends on capacity demonstrated in the screening and recent training tolerance. So if the athlete has just cleared the impact preparation, I start at level 1 or the phase 2 walking program, which is roughly 1.5 to 2 total miles per week, 2 to 3 runs per week, and at least 48 hours between runs, all in easy pace on flat ground. If they're already tolerating short symptom-free walk jog bouts outside the clinic and show strong plyometric preparation, I may start a level higher. The athlete moves up a level after completing the current level 3 times with no symptoms during the session or within 24 hours and at an easy effort. If symptoms appear or worsen, I perform a gait check and immediately step back 1 level before rebuilding. A small technical adjustment that often helps is cadence. So if the step rate is below 170 steps per minute, I try a 10% increase, which commonly reduces ground reaction forces and improves comfort. So to do this in clinic, I have a patient on the treadmill and I have them run at their easy pace, and I look at 1 foot and I count their footfall in usually 30 seconds. And then I multiply that by 2 to get a minute. And then I multiply it again by 2 to get both feet. And that comes out to the cadence. So finally, with this decision tree, remember that the strength and running pathways can move asynchronously. If the run screen is not yet a pass, we can continue building strength even into plyometric preparation so that the next screening is a success. So these are the run readiness, strength, and load impact screens from both of the articles, actually, which I mentioned earlier as a resource to you. I use these in the clinic and I show the patient what I'm looking for. I'll even send this to patients ahead of time so they can see what the expectation is. And this is more of that. And then these are the run progression phases from the Christopher article. So they are very conservative and slow, but I think it is a really good starting point for someone who doesn't have experience working with the athlete, especially in the postpartum athlete, and who doesn't have coaching experience. I will use this in clinic, but I will also use my clinical judgment to create custom programs for people for return to run. And then these are just the directions on how to use the phases from the study as we just walked through. So 3 takeaways from this. 1, with an uncomplicated pregnancy, exercise and running can be safe when we follow simple rules and monitor symptoms. 2, pregnancy changes explain many symptoms, so we teach proximal strengthening, single leg control, and calf and foot strength. Then we fine-tune running form if possible. 3, in the 4th trimester, we use time to protect healing and criteria to progress. Together, they create a clear path back to running. Happy to take questions now.
Si alguien tiene pregunta, pueden quitarle el mute y pueden hacer las preguntas que gusten. I'm going to start with one, Claire. One question. Any recommendation about footwear? Because, the evidence is not the best, but, but your recommendation, you recommended for this type of population, any specific type of shoes, footwear for running?
Yeah, I always tell my patients or athletes to go to the running store where they can where you can try the shoes on, and you should immediately feel comfortable in the shoe. You shouldn't have any sort of like time where you have to wear them in. So no specifics, but it's mostly having to try them on themselves. I definitely like the brand Brooks, if I were to say my biased opinion, but otherwise, yeah, just going to the local running store and trying on the shoes.
Okay. Any other question? Don't be shy. You can ask whatever you want. Miss Benedetto, Professora, you have any question?
I don't have any questions right now.
Oh,
Can you hear me?
Yeah.
Yeah, I'm not familiar with this particular population. I'm familiar with postpartum exercise, so I'm just taking it on, and I think it's great. So I appreciate the wealth of information and yeah.
I know it was a lot, so I can share pieces of the presentation, like well, it's also in the articles, like the run readiness screens and the phase progressions and things like that. But it's a really good guideline for people to help these runners back.
So Claire, how often, so you have a combination of coaching and PT proper between what you presented here. How often do you see women postpartum that want to get back to running in the clinic versus, work on this, then come back, et cetera? What does it typically look like? And these are elite athletes that have run, and they're going to get back to an elite level of running. So how do you manage that?
I love seeing patients like starting in the second trimester, even in the first trimester, and then just guiding them through exercise changes during each trimester, giving them run training advice, getting them prepared for birth. We do birth prep in pelvic PT, so we teach people coordination of how to relax their pelvic floors, how to push with breathing, to prevent tears and things like that.
Are you
Super
getting
fun.
referrals from the OBs?
What'd you say?
Where are your client population coming from? Referrals from the OBs at Penn?
Yeah. Uh-huh. And then I tell them to ask their OB or midwife for a referral while they're still in the hospital. And I have them come back like 4 to 6 weeks postpartum. And then I start right away with like how I was showing you on those slides, those sort of exercises, breath work, coordination. And then, yeah, I take them basically what we just presented, like take them through and.
But are you seeing them once a week and once every 2 weeks?
Oh,
So you're doing consultation. How do you manage that?
yeah, it depends. Probably with these high level, it depends what they have going on, but I guess someone with a less complicated pregnancy and I'm just more so like monitoring their running and stuff, it might be every like 2 weeks or so. I never see people more than once a week.
Yeah. Okay.
Yeah.
That is good. That is important because sometimes the insurance they don't cover too many appointments, or especially in Puerto Rico. Is that the insurance they play with the health of the patient, to be honest with you. So other question. Not question.
okay.
It's
I have
comment.
one. I have one.
Okay, do it,
Okay.
Moise.
Okay. On what specific adjustments are recommended or should recommend more for the running across the different trimesters? So especially regarding the changes of balance, pelvic floor function, and lumbar stability. You know that in each trimester there are changes in the body. So there is a specific recommendation for working with that changes.
Yeah.
You got it?
Let me go back. Oops. So, in the first trimester, there's a lot of what we're worried about is like the nausea, not being up for training, things like that.
Mm-hmm.
But physically, there's not, you don't see as much happening, although there's
Mm-hmm.
a lot of the hormonal and cardiovascular things happening that aren't visible to us. So we're just being cautious of the risk of miscarriage in the first trimester. So we're being very conscious of cooling strategies, being really careful with our caloric intake, things like that, taking longer warm-ups. But otherwise, if you're feeling good, you can continue at a similar level. You just have to be aware of that. And
Okay.
then second trimester is kind of like our sweet spot in training. The nausea reduces. You're not as big as you will be in the third trimester. So this is a really nice spot where people can go and continue with some intensity, like I was saying, that tempo effort. Of course. Also a nice time to start with like the belly bands for some of that pressure that might be starting.
Yep.
And to help with that change in center of mass.
Okay. That's good. Okay.
And then the third trimester is where we would be changing with more cross training, incline walking or running because of that balance you were mentioning, balance changes. And then there's more walk run intervals at this stage as well.
Okay.
That answered.
So you recommend for this after the second trimester more pelvic floor exercise to get more control because of the laxity of the tissue and everything of all that changes? Or
I definitely start training in the beginning, or strength
okay.
training in the beginning, right away in the first trimester. Actually, in the third trimester, we might do more things, like relaxing the pelvic floor. I mean, that's
Relaxing.
getting into more
Okay.
nitty-gritty, but to prepare for birth,
Mm-hmm.
the pelvic floor needs to be relaxed to allow
Yep.
baby to come out through the vaginal canal. So in the late third trimester, I actually teach relaxation rather than strengthening. But before that, yes, we're doing a ton of pelvic floor and core strengthening.
Okay. Thank you very much.
Yeah, you're welcome.
I have a question.
Mhm.
Let me just, I want to see you. I want you to see me. Regarding if a patient postpartum have any like pelvic floor symptom like incontinence or prolapse, do you still continue with the running training, or will you stop that? Maybe focus on strength and like I just want to know if you completely like resolve or treat the prolapse or urinary incontinence before going to like the impact of running.
Meg, you want to answer?
Can you repeat some of that question?
I'll try. Yes. Okay. So I want to know if a postpartum patient have, let's say, prolapse or urinary incontinence, and they want also to start running. If you do one thing first and the running later, or if you like go together based on what the patient is feeling.
Yeah, so if I answer this, if I'm not answering your question, just re-ask it again. But for a patient with prolapse that's coming to us that wants to continue or start running, I think the first thing that I would do, and I think Claire would do too, is to assess what their symptoms are with that prolapse. Because prolapse can result in a lot of different symptoms. So kind of first treating those initial symptoms, whatever they are, and then working on things probably with a prolapse patient, like a pressure management system first. If they don't have that proper pressure management in their thoracoabdominal cavity, then they're probably just going to make that prolapse worse no matter what they're doing. So trying to get that under control. And then if there's a weakness to the pelvic floor, try to strengthen it, progress that to more of a functional plan of care and then into the running. Or if if the pelvic floor is too tight or it's overactive, trying to down train it a bit and then again progress to the running. So I wouldn't necessarily say that I would do running right off the jump. I would try to see what they're coming in with and decrease those symptoms and severity at least, and make sure they're safe.
Yeah, and I guess if they were already running and they're having these symptoms, like when do you cut them off? I guess is the question, right? Because that's always a hard conversation. So I think it's like I would probably take a step if it's significant symptoms, I would take a step back with running. I would either reduce to a walk run, look at their form, their mechanics, talk about their training. Are they running at too fast of a speed for their physiology and fitness? So they've definitely been making adjustments. I wouldn't always cut running off completely if they were already running and are experiencing these symptoms. I would try to make a modification or change first.
Thank you, guys. That helps. That answered my questions. Both of you. Thank you.
Sorry, my Wi-Fi cut out.
She is also a pelvic floor specialist. So
Oh, really?
Yeah.
Yes, I am, but I don't do running.
Oh,
But that was great. Thank you for everything.
yeah.
The pregnancy women, twins, etc. Is there different criteria for them, or do you follow same previously discussed? Thank you.
Can you repeat that?
Yeah, they ask if you work with multiple pregnancy women, like a twins, etc. Is there a different criteria for them, or do you follow same previously discussed? So depend how many kids you have, if you continue with the same protocol or you use different because the amount of kids.
Oh yeah, that's a great question. It just depends on if they have any restrictions from their doctor. So if they have the okay to continue with exercise, then we don't have to abide by any precautions necessarily. We just have to really monitor their symptoms, because people with twins can be at a higher risk for things like prolapse, incontinence, perineal lacerations, things like that. So no, we can continue training, but it's just monitoring.
And when you say that the continual water run program, the biomechanic, the posture and everything, do you recommend that record by the patient, record the training that they can see how can do it, that have feedback, or what do you do? Because you see it one time per week or two times per. So how the person is going to see that is doing correctly in case of you do it virtually appointments or.
Yeah. I have them tell me what they were doing, and sometimes I'll look at their wearable, their Garmin watch. They have an app and it shows like the runs they do in the past month or week or whatever. So I'll look at a lot of people's data in the clinic, and it doesn't take long at all. Yeah, that's how I do it.
Okay. Is that in my case that I saw a lot of soldiers, pregnant women in there. So the major time I put in the treadmill and I put the telephone of the patient and say, okay, you can put in the floor and you can record and you go to do it. You can see if you're doing right, you're doing wrong, you overcompensated, all the things. So I say that try to do certain time of in the side and then in the back. So put in different angles the camera to see how he's doing or how she's doing the running.
Oh, I see what you're asking about, running analysis.
Yes.
Oh, I'm sorry. I will do that in clinic.
Okay.
Yeah. So I take my iPhone and I do the slow motion video capture, and I will get them from behind, from the side, and from the front. And then I'll also zoom up on their feet, and then I slow it down. I also count the cadence like I was telling you about, where I do the foot count. And if they're below the 170, then I try to change that usually.
Okay. And for how long, how many minutes you record, you evaluate the person?
I have them start warming up for like 2 minutes maybe.
Mm-hmm.
And then I start recording and
Okay.
I record for like 30-second clips or something.
Okay. Okay. Yeah.
Yeah.
I do it like a 30 second to 1 minute. No more than.
Yeah.
Okay. Okay. Any other question? En confianza pueden hacer las preguntas que quieran. Aprovechen. Si quieren repetir otras preguntas, pueden hacerlo.
También pueden hacer la pregunta en español y traducir.
Exacto. Que en confianza.
Yo tengo una pregunta.
Dale. Tírale.
Um, so I guess my question is a little bit long because I've been trying my best to like formulate it as best as possible. But in the island, there's been like this boom of like running clubs, and it's usually been filled with people that haven't necessarily been doing track or running or any type of sport previously, like in their youth. And I guess my question goes towards more, is there like a time frame that women should have been running before they could be cleared to do like PT while pregnant, like running while pregnant and training with you guys? I'm not sure if I'm making sense. Like for example, like if a pregnant woman were to go to you to like get coached for running, should she have been already running for X amount of time before doing that?
I would definitely prefer that. Yes.
So is there like a time frame that you should use? Like if they were to be amateurs, but like they've been in this running club, let's say like for a year, is that like a good time frame to
Yeah.
continue? Or like is there a minimum or a maximum that I should be aware of just in case? Like so I can like suspend the running and maybe do more modified things or no?
Yeah, that's such a good question. I don't know if I have a time frame. I would just say that like I wouldn't start running in pregnancy. Like that's not the time to be improving like or just trying something new and improving your fitness when you don't know how your body responds to it outside being pregnant. I think if you started running like I don't know, like I'll say like 3 months before at the minimum, then it's probably fine to continue. What do you think, Meg? That's a good question.
And see, this is when I would go ask you. This is when I'm like, Claire. No, I think 3 months is probably appropriate. Like it takes at least 90 days to create a habit. So like whatever habits you do have, whatever you have established are there at that point. So you're like at least you're consistently doing whatever you are doing, good, bad, indifferent. So I don't know. That would be my take on it.
And
I say if you're a newer runner,
don't you think that you
okay.
need that amount of time for physiological changes for adaptation? So 3 months is a good amount of time that you would see physiological adaptation throughout the body system so that when the woman is pregnant and is going to go through all these changes, it won't be such a shock to the system, if you wish, as long as they're monitored. But if the ACOG, I mean, most docs will say what you were doing previously is fine. Don't start something new.
Right.
No, don't go out and play 3 rounds of pickleball if you've never done it before.
Yeah,
Yeah.
that was a really good question.
¿Alguna otra preguntita? En confianza, aprovechen. You're welcome. Nada, si no tienen más preguntitas, thank you, Claire. Thank you, Megan, to be here, to spend your time, your expertise. It's so honored to be here with you and hear you both. Thank you for everything. Anything that you want, we are here. If you want to come to Puerto Rico to do a presentation, we can try to do it in the future. Yeah. We can do something. We can think about it. Benedetto and me, we're going to sit down later and we can see if we can do something in Puerto Rico together with all the people
I
that.
already started whispering in Claire's ear, saying, "Hey, hey."
Yeah, no, it's very good, and we can also put together with the pelvic floor, especially in Puerto Rico. We have like a Jennifer is still here. Jennifer Tataki.
Yes, I'm here. Yes.
How many PTs, specialists in pelvic floor in Puerto Rico we have right now? 3 or 4, something like that?
We have, I think, 4 to 5 specialists
Okay.
right now. Yes.
Okay, so yeah, I know like a 3, right? Like the others, I don't know, but
In the VA system has 2 new PTs.
okay,
Yeah.
perfect. Oh, good. So we don't know. We can do something in Puerto Rico, share it together, and do something.
I approve that message.
Yeah, no, I think it's great. To be honest, we got to think about it, and you know the people that know me, when I think something, I got to do it.
And we have to make sure we get the dates right, Luis.
Yeah, well, exactly. Yeah, sorry. That was so.
Otherwise, Claire and I are going to run to the beach together while we're waiting to figure out which date it is. We'll go have a pina
But,
colada on the beach.
but once again, thank you. I'm going to change the presentation. I'm going to put something.
Okay.
So let me. Sure.
Oh, do I need to unshare?
Let me probably.
Yeah, probably.
And let me put it in here now. There we go. So, let's see this. No, is this? Sure. There we go. So, están viendo mi pantalla, ¿verdad?
Yep.
Okay. Now presentation. There we go. Let's see if I can open here. So, como les dije al principio, le tengo que dar gracias a los auspiciadores, ¿verdad? Y tengo aquí a uno de ellos, que es a Moisés Cartagena, uno de los que hizo la pregunta. Moisés, saludos.
Saludos.
Mm.
¿Me oye?
Sí, yo te oigo, te estoy oyendo. Que estoy tratando de abrir la pantalla mía y no sé por qué no la puedo abrir. Cuéntame, Moisés, ¿qué cosas nuevas hay pronto ahora?
Pues mira, en verdad, aquí en Puerto Rico, pues tenemos, gracias, thanks for your presentation, it was great. We're going to share later. Pero pues aquí pues tenemos, ¿verdad? Varias actividades a nivel de ciberterapia. Tenemos un curso de educación continua de 4 horas que se va a estar dando en 2026 por cuestiones pues, programáticas y para tener seguro el código, que tanto terapistas ocupacionales, físicos y asistentes de terapia física puedan participar, pues ya lo vamos a dar en UPR Macao en 2026. Y vamos a estar también como parte, ¿verdad? Ya sea de terapia física PR o desde ciberterapia, vamos a estar apoyando el simposio de PT Today, así que pues tan pronto, ¿verdad? Ya hicimos el acercamiento a Lizardi y al grupo de PT Today para entonces estar ahí auspiciándolo. Y ahí tenemos pues, diferentes cursos que están en agenda, que pueden visitarlos en terapiafísicapr.com. La idea es pues, promover cualquier curso de educación continua a nivel de terapia física o a nivel, ¿verdad?, de temas relacionados que nosotros podemos beneficiarnos. Hay un curso de acuaterapia que se va a estar dando el 22 de noviembre. Ese curso son 4 horas, es un curso introductorio, así que si a una persona le interesa la acuaterapia, pues es una buena oportunidad, es con Yara Marán. Y la idea es pues, darle sus primeros pasos para conocer lo que es la acuaterapia. Y también está la actividad de recinto de ciencias médicas, que es una actividad que se da todos los años, lo coordina en ciencias médicas, el recinto, el programa, y está abierto para diferentes profesionales de la salud. Ya terapia física ya tiene código, así que pues ya por lo menos las horas contacto están aseguradas y otros profesionales, nosotros pues vamos a estar actualizando eso. Y pues CSM, ayer fue el último día para el Early, así que les invitamos, ya yo estoy apuntado, vamos para allá, a ver las cosas nuevas que hay de todos los ámbitos. Y es en Anaheim, así que pues vamos, ¿verdad? A estar participando por allá. Así que todos los estudiantes, todos los que van a estar de Puerto Rico, pues sería bueno encontrarnos nuevamente. Y está la estimulación neurológica, ese que está ahí primero, que es el próximo curso. Estoy tratando de abrirlo, pero Luis quizás puede verlo, hablar allá.
Ajá,
Pero nada, cuento algo corto. Para terminar, ciberterapia.com se abrió un espacio para tanto terapia física que se diera en telehealth, pues ahora mismo está abierto, ¿verdad? Con la ley que no requiere certificación adicional, pues para que los terapistas que no son diestros en la parte de la tecnología, pues puedan crear al costo mínimo un espacio donde ellos pueden montar su página web pequeña y además pues, acceder a servicios que cumplen con IPA y la privacidad. Así que nada, exploren las páginas y gracias Luis ¿verdad? Por permitirnos
de
difundir la
nada.
información.
Para eso
Gracias.
estamos. Hey, Claire, by the way, do you see your patient also virtually or is all the time is in person?
For physical therapy, it's all in person.
Okay, perfect.
Mhm.
Eh, eh, Otra cosa, un Corp nos envió esto que tienen en especial mientras duren este TENS que tiene Russian Steam Interferential EMS. So, está a 155, así que le dicen que lo vieron aquí y le van a dar ese precio. Y es mientras duren, es el de esa foto. Eh, Simposio de PT Today 2026, 2026, is going to be en el recinto de ciencias médicas este año. Así que gracias a Dios ya podemos decir que va a ser el recinto. 2021, 20 va a ser talleres, si Dios quiere, estamos trabajando en eso. Si Dios quiere, vamos a incluir los asistentes este año en los talleres. Y el 21 va a ser las presentaciones. Todavía estamos haciendo la lista de cuáles presentaciones vamos a hacer, ya tenemos básicamente casi todas, pero no quiero adelantar. Y los talleres, pues estamos trabajando en eso. Estamos afinando un par de detallitos que tenemos que afinar de logística, pero ya está oficializado gracias a la profesora Font y al Recinto de Ciencias Médicas que va a ser allí, en el anfiteatro. Y por último, y no menos importante, la beca PT Today, que se va a dar por segundo año a estudiantes de terapia física y asistentes del terapista físico. Así que pronto vamos a subir los requisitos, el link para subir documentos y para que soliciten. Así que pendiente a eso. Y nada, yo creo que tengo todo lo que iba a decir. Si alguien quiere decir algo, ¿alguien más? ¿No? Nada, pues buenas noches. Thank you, Claire, once again. Thank you, Megan.
Thank you so much for having us. This was really great.
Yeah, and once again,
Are you good?
Yeah.
Okay.
so, antes de empezar, profesor, que usted lo presente, déjame decirle en español un par de cositas.
Ajá, diga.
Nada, saludos a todos, ¿verdad? Buenas noches, pues estamos mucho, digo, ya estamos de noche en todos lados. Así es que la diferencia ahora, yo tengo dos horas de diferencia de ustedes y Megan y Claire tienen una hora de diferencia, igual que la profesora Benedetto. Gracias por venir, ¿verdad? Gracias por estar con nosotros. Le queremos dar las gracias a Megan and Claire to be here, to spend the time with us to talk about this topic that is very, very, very good and unique because not all the people knows about this topic. And with all the years, the proof of running in women's is getting higher. So in Puerto Rico, they love to run. To be honest, one of the favorite sport in Puerto Rico is run. Is what it is. Basketball, baseball, and running is one of the best. So. Importante, los que quieran pueden poner el closed caption. Si ustedes van si no me equivoco, a more, dice que dice captions, el segundo, y ahí pueden poner el caption y pueden, todo lo que se diga, lo pueden estar leyendo también ahí por si acaso quieren hacerlo de esa manera, ¿verdad? Eh, eh, la conferencia se va a grabar y si Dios quiere, pues se subirá en la página de Period Day en YouTube pronto. Se puso en el chat los artículos que ya van a mencionar en la presentación. Si ustedes no lo ven, me dejan saber cualquier cosa. Yo voy a poner el email de Period Day en el chat y pues nos pueden escribir y yo se los puedo enviar en confianza. O sea, si tienen problema en bajarlo o que no los vean o qué sé yo. Así que con todo eso, le quiero dar las gracias también a los auspiciadores, ¿verdad? Que nos han ayudado siempre en todos nosotros, en todas las cosas, en Corp, Best Option, Cyber Therapy, eh, Raúl con su compañía de Puerto Rico Physical Therapy, ¿verdad? Eh, Todos, de verdad que se le agradece que estén, que nos ayuden, ¿verdad? En todo esto. Así que sin más, nada que tenga que decir, profesora, todo usted.
Gracias, buenas noches a todos. Es un gran placer estar con ustedes y presentarle a Claire Todd, DPT, y Meghan Nally, DPT, ambas que son especialistas en rehabilitación de mujeres embarazadas que corren durante y después del embarazo. Además, tienen especialidad en rehabilitación pélvica. Claire lleva más de 10 años, casi 10 años de terapista física. Megan 3, las dos hoy día trabajan en ¿cómo se llama? Ambulatorio, Luis, así se
Sí,
dice.
en el hospital, pero en
En
el
el
área
hospital
ambulatoria.
de la Universidad de Pensilvania, en ambulatorio ortopédico. Claire fue estudiante mía, así pues, yo estoy muy, muy, muy orgullosa. Estoy muy emocionada, entonces voy a dejar que ella hable un poquitín sobre su experiencia en particular con las mujeres. Gracias y muy buenas noches. Claire and Megan, please, just a brief introduction about your particular expertise with women, pregnant women, and running.
Yeah. Hi, I'm Claire. So, as Maria said, I'm a physical therapist in Philadelphia, specializing in pelvic health and orthopedics. I'm also a running coach. So, I coach runners mostly long distance from half marathon to 100 miles. And I'm also a runner myself. I've run Boston Marathon multiple times, and I've run 100 miles myself as well. So it's truly my passion, and I love that I can meld both worlds together of orthopedics and pelvic to treat the pregnant and postpartum runner.
I'm Meg. I work with Claire actually, and I also treat the pelvic floor and orthopedic populations. I am not a running coach, and I like to run, but not like Claire. Claire's the runner here, but I played high level sports for a long time. So, working with Claire and getting to know Claire, she's piqued my interest in trying to maybe rehab some runners here and there, but I also do enjoy treating pregnancy and postpartum, getting people into or back into exercise throughout that cycle.
Awesome.